Kia ora. My name is Diane Kenwright and I'm a pathologist from Wellington. Originally, we designed the session to be face-to-face and interactive. However, today we're online. You'll notice that there are a couple of places where we ask you to do some exercises. We can't do those today. If you do want to run this lesson with your lab, then a copy of the video will be available from the Institute's IT. Kia ora. My name's Diane Kenwright and I'm a pathologist from Wellington. Thank you for joining us today to learn about cervical specimens. We originally were going to do this live and had some fun exercises for you to do. Unfortunately, here we are in a virtual world. If you do want to do the exercises later in a time where your whole lab can watch this presentation, then the presentation is available from the events manager at the Institute. If you email him, then he can send you a copy that you can use and pause at the right places.
Hello, I am Britton Cavanaugh, a pathologist assistant at Wellington SCL Laboratories, and I will be presenting alongside Diane Kenwright, an anatomical pathologist at the Wellington Laboratories and a professor at the University of Otago. In this presentation, we will be talking about cervical specimens that you may see in the anatomical pathology laboratory. We will begin with some general instructions covering anatomy, specimen types, and pathology. We will then demonstrate how to handle common specimens in 3 videos. After that, you will get a chance to apply what you have learned today before a short review of the material. Let's begin with an interactive review of the anatomy of the cervix. In this exercise, we would like you to draw the anatomy of the cervix and its associated structures. Now here we have the image of a uterus. The cervix lies at the lower pole of the uterus, beginning at the internal os and extending to the external os. The cervix consists of the outer ectocervix, the external os, or the external opening, the endocervical canal, the internal os, and the surrounding stroma. The internal os constitutes the superior border of the cervix, and the external os constitutes the inferior border. And in general, cervical biopsies are taken from the ectocervix and the external os. LLETZ specimens are also taken from this area, and cone biopsies are taken from the lower and innermost portion of the cervix. Now, the ectocervix is lined by squamous cells, and the endocervical canal is lined by columnar cells. The junction point between these 2 cell types is called the squamo-columnar junction. Now, this is a junction which moves in and out of the canal depending on the individual's age and their hormone levels. This movement creates a transformation zone as the cells transform from columnar to squamous and from squamous to columnar cells. Now, this transformation zone is a very important area in pathology because these cells are prone to HPV infection, and this is often the area where abnormal cells arise. Now, we often view the cervix from the posterior surface, similar to the view during a colposcopy. This is as if the woman was lying on her back. In this view, the top is anterior, the bottom is posterior. What we see on the right is the patient's left. What we see on the left is the patient's right. And again, this is because we are viewing the specimen as if the patient is supine or lying on her back. Now, cervical specimens can arrive oriented by the surgeon, and usually they are oriented with a stitch or ink at anterior or 12 o'clock when the clock face approach is used. Now, the clock face technique applies a clock template to a specimen, which allows for orientation that is independent of anatomical orientation. Now, this common approach provides accurate coordination between the clinical and the laboratory settings. Now we will talk about specimen types, but first it is time for another interactive activity. Please list at least 4 of the cervical specimen types that you see commonly in your laboratory.
How did you get on thinking about the types of specimens? Here's my list. When thinking about biopsies, we can often divide them into biopsies that are just diagnostic biopsies and biopsies that are both diagnostic and treatment. We aren't going to talk about pap smears here. It's a screening biopsy rather than a diagnostic biopsy. The most common biopsy that we get is the cervical biopsy. This is colposcopically directed. That means it's taken down a colposcope, this device where a microscope is used to examine the cervix. They're often quite small, and they sample what are called aceto-white areas. These are white areas on the cervix that can be seen after the cervix is painted with acetic acid, and usually these are areas where there is CIN. Also really common is the cervical polyp. These can just often be popped off by the person doing colposcopy and then popped into formalin and sent to us. Much a rarer diagnostic biopsy is the endocervical curette. This is used where pathology is suspected to be up inside the endocervical canal and there's no visible lesion. What we get is this mixture of mucus and small fragments of tissue that often has to be put in a cassette between, say, paper or a sponge so that we can see the tiny preserved fragments. The other type of biopsy is the biopsy that's used for treatment, and that usually comes a few weeks after someone has had an initial diagnostic biopsy. Most common is the LLETZ biopsy. So this is where an electrified loop excises a saucer-shaped piece of tissue at the transformation zone. It's used for all kinds of CIN and sometimes for adenocarcinoma in situ. The less common kind of biopsy and much larger is the cone biopsy, sometimes called a cold knife cone because it doesn't use diathermy to take out the lesion. It's much bigger, it's used for adenocarcinoma, and it's used for small invasive cancers. In this diagram, we can understand how a LLETZ is performed. On the left-hand side here, we have the instrument doing it. It's an electrified wire, and it's used to take this saucer-shaped excision of the transformation zone. Sometimes people performing LLETZ will in fact do it in two halves, a top half and then the bottom half. And sometimes after they've completed it, they will go on and do what's called a top hat, which is a further re-excision of the deep endocervical canal. This is a picture of a cone biopsy. You can see it's quite a large piece of tissue. It includes the transformation zone and the adjacent cervix, but also goes very, very deep into the endocervical canal and also very deep into the stroma. It's called a cone biopsy because in profile it's cone shaped. So these are used where a large amount of tissue has to be removed, such as invasive cancers or adenocarcinoma in situ. And they can cause problems in later pregnancies because it means that the cervix has difficulty maintaining competence in later pregnancy. Let's think now about the microscopy of the cervix. First the normal cervix and then the abnormal cervix. Let's think about the normal cervix. So the cervix has squamous epithelium on the outer part of it. This is the normal squamous epithelium. Notice at the bottom there are dark blue coloured basal cells, but most of the epithelium is taken up by these glycogenated cells. This is in the premenopausal woman. In the postmenopausal woman, the glycogenation can disappear. The glycogenation gives the hollow look to the cells. This is a normal cervical gland. It's lined by a layer of basal cells and then some apical mucin. The normal cervical glands show very, very few mitoses in the base here, and the nuclei are all really, really regular. And that helps us differentiate it from any atypia that we see, for example, in adenocarcinoma in situ. We call the cervical glands, but in fact they're really crypts or pseudoglands. So this is the surface epithelium here, the squamous epithelium. And as part of squamous metaplasia, it is covered over the surface of a gland here. And we can see that this gland actually connects to the surface and is a crypt rather than a gland. So as squamous metaplasia happens, we can get the squamous metaplasia going into the glands here. Glandular extension of squamous metaplasia. This isn't invasion, this is a normal physiologic process. We're going to think now about some common pathologies. The first pathology we're going to think about is endocervical polyps. These are really common. In this quite large one here, we can see the cervix, and the polyp is peeping out of the external os. So quite often these can just be quietly avulsed and sent along, or they can be taken out with diathermy. And we get a specimen that looks like this, where we have a little polypoid protrusion with cervical glands in the middle, and usually covered by cervical epithelium. They're this lovely bright cherry red color and very distinctive. Usually they're single, but they can be multiple. Let's move on to think about cervical intraepithelial neoplasia. The lowest grade of this, caused by HPV, is CIN1. In CIN1, we lose the nice regular basal cell line that we get in normal epithelium, and here they become of increased thickness and of larger size. In the upper part of the epithelium, the upper 2/3, the cells still look abnormal. They have a halo around an enlarged nucleus, which is called a koilocyte. The perinuclear halos, nuclear irregularity, and nuclear hyperchromasia is typical of CIN1, but the basal cells are confined to the lower third. Here we have CIN2. It looks somewhat similar, but the immature type basal cells now are filling up the gap between the 1/3 and 2/3 marks. So it goes up to 2/3 thickness for these basal cells. We also get some mitoses associated with the basal cells, and they are again confined to the lower 2/3 of the epithelium. We can get abnormal mitotic figures associated with CIN2. In CIN2, the HPV types that cause this are the high-risk types. So things like HPV 16 and 18. This is CIN3. We notice now that the basal cells have filled up the whole thickness of the epithelium. So the immature basal cells can have, again, atypical mitoses, are pleomorphic and hyperchromatic, and are associated with those high-risk HPV types. That is Here we have CIN3. Now you notice these immature basal cells have filled up the whole epithelium. Like the other basal cells, they are hyperchromatic, pleomorphic, and because they're caused by HPV 16 and 18, they have atypical mitoses. Note, however, that there is no invasion into the underlying stroma. Here's the line between the epithelium and the stroma, and it's nice and regular. I talked earlier about aceto white. This is a picture of a living cervix that has been painted with acetic acid, i.e. vinegar. And you can see that there's an area of whiteness. This is how the areas of CIN are detected by the colposcopist, the doctor who's looking at the cervix. And this is how he knows how to direct the biopsy. Moving on from CIN, we can see here an invasive squamous cell carcinoma. What we have here is CIN3, which has migrated into glands, not yet invasive, but suddenly it breaks through the basement membrane, and we now have these areas of invasive squamous cell carcinoma. And if this isn't removed, it will progress. As well as the squamous parts of the cervix, the glandular parts can become atypical as well. If the atypia is confined just to the glandular epithelium, it's called adenocarcinoma in situ. In this picture here, we can see a normal gland with small basal epithelium and apical mucin. But here we can see that the cells have formed multiple layers. They have atypical mitoses, they're hyperchromatic, and look, some are very pleomorphic. So this is adenocarcinoma in situ, a precursor to invasive adenocarcinoma. Here is invasive adenocarcinoma. We have glands invading the stroma of the cervix. Adenocarcinoma of the cervix is caused by the same high-risk HPV types as invasive squamous cell carcinoma.
We will now demonstrate how to handle 3 common cervical specimens. These videos will be provided to you for future reference. We have also created checklists that will walk you through the dissection of each cervical specimen. Both the videos and the checklist will enable you to dissect the most common cervical specimen types following the RCPA guidelines. Let's first begin with a cervical biopsy. This video will illustrate the dissection of a cervical biopsy. The video will cover examination and processing of cervical biopsy specimens. Cervical biopsies consist of a small fragment or fragments of cervical mucosa and stroma. Due to their small size, orientation is not necessary. Record the number of tissue fragments and the greatest dimension or a range in the greatest dimensions. When relevant, record the shape, color, and consistency of the tissue. If the specimen is small, you may want to note that the tissue may not survive processing. Add the appropriate levels, and the specimen is ready for processing. This is the conclusion of the cervical biopsy dissection video. Thank you for viewing. We'll learn how to handle LLETZ specimens. This video will illustrate the dissection of a cervical large loop excision of the transformation zone. This video will cover orientation, external examination, inking and sectioning, internal examination, and processing. Orientation. Large loop excision of the transformation zone specimens, or LLETZ specimens, are often rectangular in shape with a central defect representing the external os. They may be received oriented or unoriented. They are generally oriented with a single suture or ink designating a specified position, such as 12 o'clock or anterior. The clockwork technique utilizes a clock face template to orient specimens that is independent of anatomical orientation, allowing for accurate coordination between the clinical and laboratory setting. External examination. LLETZ specimens will be made up of 3 components: ectocervical mucosa, endocervical mucosa, and stroma. Normal ectocervical mucosa will be smooth, glistening, and white. Endocervical mucosa may be smooth, pink, tan, or white. Normal stroma will be roughened, dull, and may be cauterized. Measure the specimen in 3 dimensions, or if the specimen consists of multiple fragments, measure the range of greatest dimensions. Measure the diameter of the external os. If tumor can be identified, describe the appearance, size, depth, location, relationship to the os, and distance to the margins. Inking and sectioning. Ink the resection margin, ensuring the entire margin is covered to the mucosa. If the specimen is oriented, ink the anterior half one color and the posterior half a second color. Section the specimen at 3 mm intervals perpendicular to the long axis of the os, so that each slice will include the transformation zone. If the os cannot be identified, section the specimen perpendicular to the long axis. Internal examination. If tumor can be identified, describe the lesion, depth, invasion, and distance to the margins. Processing. Submit the entire specimen sequentially, working from one end to the other. If the specimen is oriented, specify the 3 o'clock and 9 o'clock ends. Add the appropriate levels, and the specimen is ready for processing. This is the conclusion of the cervical large loop excision of the transformation zone specimen dissection video. Thank you for viewing. And finally, the third video will illustrate how to handle cone cervical specimens. This video will illustrate the dissection of a cervical cone specimen. This video will cover orientation, external examination, inking and sectioning, internal examination, and processing. Orientation. Cervical cone specimens are often conical in shape with a central defect representing the external os, an endocervical canal, and an internal os. They may be received oriented or unoriented. They are generally oriented with a single suture or ink designating a specified position such as 12 o'clock or anterior. The clockwork technique utilizes a clock face template to orient specimens that is independent of anatomical orientation, allowing for accurate coordination between the clinical and laboratory settings. External examination. Cone specimens will be made up of 3 components: ectocervical mucosa, endocervical mucosa, and stroma. Normal ectocervical mucosa will be smooth, glistening, and white. Endocervical mucosa may be smooth, pink, tan, or white. Normal stroma will be roughened, dull, and may be cauterized. Measure the ectocervix in 2 dimensions and the length of the specimen. Measure the diameter of the os. Measure the length of the endocervical canal upon sectioning. If tumor can be identified, describe the appearance, size, depth, location, relationship to the os, relationship to the canal, and distance to the margins. Inking and sectioning. Ink the resection margin, ensuring the entire margin is covered to the mucosa. If the specimen is oriented, ink the anterior half one color and the posterior half a second color. Otherwise, ink the entire margin one color. Section the specimen at 3 mm intervals perpendicular to the long axis of the os so that each central slice will include the transformation zone. If the os cannot be identified, section the specimen perpendicular to the long axis. Internal examination. If tumor can be identified, describe the lesion, depth, invasion, and distance to the margins. Processing. Submit the entire specimen sequentially, working from one end to the other. If the specimen is oriented, specify the 3 o'clock and 9 o'clock ends. Add the appropriate levels and the specimen is ready for processing. This is the conclusion of the cervical cone specimen dissection video. Thank you for viewing. The videos you just watched and the provided checklists were created using the RCPA guidelines. Further information can be found within the RCPA resources. These guidelines explain what information needs to be recorded in the macroscopic description, including number of pieces, orientation, measurements, and macroscopically visible lesions. Now, between your laboratory dissection manual, the RCPA guidelines, and the provided checklists, you will be able to select the correct tissue and record the correct information necessary to assist in making an accurate diagnosis. If you have the ability to build templates for your dictations, I would recommend following the RCPA Cancer Protocol Guide checklists. And by creating these templates with this information and in the order of the guide, you will make it easier for the pathologist to sign out the case. And now you will get the chance to apply what you have learned today. For this exercise, you will need an apple, a knife, any kitchen knife will do, paper towels, a cassette or a container similar in size to a cassette, and a marker. Once you have these items, please create a punch, LLETZ, and cone specimen from your apple. Then, using the checklist, dissect each specimen while creating a macroscopic description, including things like measurements, appearance, inking, sectioning, and cassette placement. If you have a partner available, explain your steps explain what you're doing and why you're doing them. Doing this will allow you to identify and record any knowledge gaps for future reference.
Thank you for listening. Now's time for questions. Just in case you're feeling a bit shy, I've anticipated some questions that you might ask. Where does CIN most arise in the cervix? The answer is in the transformation zone, that part where the squamous epithelium is taking over from the glandular epithelium. If you have a 44-year-old woman with a referral that reads persistent LCIL, high-risk HPV positive, and then getting a LLETZ, when you put in the biopsy, what would you do? It partly depends on what the usual protocol in your lab is, but acceptable answers include put it all in with 3 levels as routine, as is done in our lab, or in some other labs, there might be a P16 put in. Another question. If you're putting in a LLETZ biopsy and have the following information, LLETZ for microinvasive SCC, how would you ink the specimen? Well, again, ideally you might want to ink the ectocervix one color and the endocervix another, but also it would be acceptable to do a single color on all the radial margins. If you're cutting a simple hysterectomy specimen which says menorrhagia fibroids previous CIN3, for the cervix samples you should sample, the answer is all in because you want to pick up all the CIN3. You treat it a bit like a cone biopsy and bread loaf it like in the video. If you're on the transfer bench and have a cervical biopsy that's quite large, 5 by 5 millimeters and 2 millimeters deep, what should you do with it? Ideally, you would want to bisect it and put it all in between the sponges. This is so that when we cut levels, we can get a really good look at all parts of the biopsy. If you receive a cone biopsy of the cervix where the clinical information says query adenocarcinoma, which of the following is true? The answer is it will be high-risk HPV positive because adenocarcinoma is also caused by HPV. You might also see CIN3 in the biopsy, but this will be because of a squamous cell that's been affected by the HPV. It's unlikely to be a metastasis from somewhere else. And of course, we want to cut a cone biopsy the proper way and not like the diagram on the left. Thank you for listening today. We're going to be live now so that you can ask me more questions.